named for short the CAS Collaborative. This collaborative is a joint initiative of Healthcare Without Harm, the Pediatric Infectious Disease Society, and an organization known as SHARP, which stands for Sharing Antimicrobial Reports for Antimicrobial Stewardship. It's my pleasure today to serve as your moderator and the chair of the CAS Collaborative. This session will be recorded. I encourage you all to notice at the right-hand upper part of your screen the chat box function. If you click on that, you will be able to communicate with our host or send questions throughout. We will reserve time at the end for a question and answer section. And at this point, I'd like to turn it over to Saul Himes, who is a steering committee member of the CAS Collaborative.
Great, thank you, Stacia. As Stacia said, I'm Saul Himes. I'm a pediatric infectious disease physician at Stony Brook, and happy to be here on this webinar to just introduce the topic of antibiotic resistance and a little bit about the CAS Collaborative. So as we have all been hearing recently about the increasing problem of antibiotic resistance, predominantly due to the overuse and misuse of antibiotics. Now, some of this certainly is in human medicine, but a significant amount of this is in agriculture. 80% of total antibiotic use is the number that regularly gets thrown around. 80% is used in agriculture. We also have the problem of a lack of new antibiotic medications. And just as sort of a reminder, this is certainly not a new problem. This is something that even Alexander Fleming, the discoverer of penicillin himself, had recognized some 70 years ago, saying that the greatest possibility of evil, if people were to medicate themselves with antibiotics, is using too small doses so that instead of clearing up the infection, the microbes are able to become resistant to the antibiotics. So to focus in on the non-human use aspect, certainly human exposure to resistant bacteria can come through a variety of ways. If we look on the left, this slide comes from David Wallinga. You have antibiotics that are given to animals. The animals have bacteria. So we eat the animals through food. We come into contact with them during the slaughtering process, handling of the animals, consumption of undercooked meat, and any bacteria that are on those animals then get introduced to us as humans. Similarly, animal workers who handle the feed, manure, can come into contact with animals and with their bacteria. And then even aside from that, the animals have the bacteria on them, they come into contact with antibiotics. Those resistant bacteria or even the antibiotic themselves can contaminate ground and surface water and can end up making their way into bacteria that are in the soil. Resistant bacteria in the animals can trade genes with bacteria in the soil, and all of those can then again make their way into humans, and thus we're exposed to resistant bacteria that sort of originate in this cycle of antibiotics and antibiotic use in animals. The ultimate real root of the issue, which is sort of bigger than this webinar, is issues of overconsumption of meat and high demands and sort of an industrialized agriculture approach that end up basically leading to sort of overuse and mismanagement of resources, including antibiotics. Because this is such a huge problem, you would think that there would be a lot of action on this. Now, one issue is that there's not a lot of awareness, especially on the part of clinicians who may work in the hospital on human antibiotic use as opposed to animal antibiotic use. And it's hard to motivate people to choose different foods. It's hard to motivate the meat industry to change their practices. There's a lot of politics involved. One of the ways that can sort of help this is for clinicians and healthcare facilities, we think, to play more of a role in this and to try to have a more consistent clinician voice in institutional policy, procurement by institutions, public policy on the part of local, state, even federal government, to really try and move the needle on this. And that's sort of where the CAS Collaborative comes in. So this is, our group is really aimed at trying to encourage clinicians to become more involved in these issues of sort of more comprehensive antimicrobial stewardship as opposed to just in human use, to look at the big picture, get involved in stewardship with regards to antibiotic use in animals, encourage their institutions to have food purchasing policy, et cetera. And we encourage anyone who is on this webinar who is not already a member and is interested in becoming a member of the collaborative to apply. The website you can see there, and to get involved. Along these lines, also, if you're trying to use your clinician voice to take action, that's really sort of the aim of this webinar, is to sort of help us as clinicians develop our voice. And so I'll turn it back over to Stacia now.
Great. Thanks so much, Saul. We have the privilege today of having a couple of speakers. This session, just so you are aware, the CCCAS Collaborative has a full membership call on a quarterly basis. And this session today, we're utilizing that time slot not only for the benefit of CCCAS members, but the broader community, to bring awareness of the kind of work that CCCAS is doing, and an opportunity for others to learn more about some of this work. But today, I'd like to introduce Julia Szymczak and Evan Lerner as our speakers to talk a bit about the opportunity to leverage the clinician voice, as Saul had mentioned. Julia Szymczak is a medical sociologist who specializes in the social and cultural dynamics of healthcare work. Her work is focused on understanding why change in healthcare is so difficult, and the socio-adaptive factors that shape efforts to improve the quality of medical care. Dr. Szymczak has received funding from the U.S. Centers for Disease Control and Prevention, the National Cancer Institute, Agency for Healthcare Research and Quality, and the Patient-Centered Outcomes Research Institute. Her research has appeared in journals such as Social Science and Medicine, the Milbank Quarterly, the Journal of American Medical Association of Pediatrics, and the Journal of Health and Social Behavior. Our second speaker, Evan Lerner, is a science communications expert who specializes in translating complex research topics into stories that resonate with broad audiences. He is currently the Director of Media Relations for the School of Engineering and Applied Sciences at the University of Pennsylvania. As a former science journalist, he understands the gulf of knowledge that exists between people inside and outside a given scientific field, and uses that understanding to help researchers bridge that gap. So welcome to Julia, and we'll pass the presentation ball over to you.
Great to see you today at this webinar. And so we're going to be splitting up the talk into two pieces. I'll begin, and then Evan will take the second half. And so really what we wanted to talk to you today is about telling compelling stories to change policy around antibiotics. So to start, we have no disclosures to make in relation to this presentation. So our objectives today are fourfold. In the first part of the talk, which I will be delivering, I just want to sort of briefly review the social dynamics surrounding antibiotic use. Like, why would a sociologist be interested in studying antibiotics? I'll be answering that question because a lot of people have that. The second is to review how a qualitative researcher approaches eliciting stories as data, because that is the method that I use in my work. And then finally, I will provide a case study of essentially how stories can change policy in healthcare based on a research study that I conducted at the Children's Hospital of Philadelphia that led to policy change at the local level that I think, although is not about antibiotics, will provide sort of a template for how to think about taking your stories, getting them to the people that need to hear them in your facility, and sort of trying to change practice. And finally, I'll pass the ball to Evan, and he will talk about, he'll really demonstrate what a story is, what makes a story effective in communicating information and engaging audiences. So the first part of the talk is really to try to make sense of this idea of antibiotic use as a social problem. And so much of my research has focused on infectious diseases related topics, and I did my dissertation research on understanding the social dynamics of organizational change in infection prevention. And that was a 2-year study around which I was really trying to understand why is it so hard to get people to wash their hands, to use aseptic technique, that sort of thing. But in the course of this study, in which I gathered a number of interviews, people started talking a little bit about antibiotics. And this is not something that I had thought about before, but as I was gathering this data, I thought to myself, this could be a really interesting next phase of research, is thinking about antibiotics. And so I just wanted to share with you an excerpt from an interview that I conducted with a pediatric general surgeon. And we were talking about surgical site infections and the challenges of categorizing an infection as a hospital-acquired or not. And he started to talk to me a little bit about antibiotics. And I wanted to share with you this quote from our interview because I think it really beautifully captures the social dynamics that are at play when we think about using a medication like an antibiotic. So here he says, if I see a patient a week after surgery and there's still a little redness and mom's nervous, I'm inclined to just put the kid on the antibiotic. It just makes everyone comfortable. And then a week later, the redness is gone. Did I treat an infection, or was there just some redness, some inflammatory post-operative discharge? I don't know. I'm more careful about how I give antibiotics than I used to be in the past. You don't want to be part of the societal issue of creating superbugs, but it's surprisingly difficult to look mom in the face when she is convinced it's infected and you're trying to say, look, it's not infected, when you don't even know for sure yourself, and a week later it could pus out and mom's like, see, should have put her on antibiotics. I can't believe you did this to my kid. That's what you imagine the scenario being if you don't do something. It's so much easier to say, look, we'll put her on a little antibiotic. And so, of course, as I was doing my data analysis, I got quite excited when I came across this passage in this interview transcript because, again, I think it really hits home that in medical organizations, really day-to-day life is made up of a series of social interactions in which people are coming face-to-face to accomplish goals, and the kinds of social dynamics that exist out there in the real world come through into the walls of the hospital and shape our interactions with each other. And so in my work, I've been really trying to think about how can we understand the different drivers of antimicrobial use. And this is just a brief, I'm not going to go over this diagram in much detail, but I pull it up just to show you that the decision to use an antibiotic is shaped by multiple factors, and not just knowledge, which is the top set of boxes. It's not just clinician knowledge of antimicrobials or disease. It's not just the availability of antimicrobials or sort of the availability of laboratory tests. It also has to do with the attitudes that physicians hold and the attitudes that patients hold. Additionally, you can embed these sorts of things in more macro-level socio-organizational characteristics, such as the healthcare system and characteristics of the organization in which people practice. As I said already, social interactions that happen in healthcare settings, so interactions between clinicians or interactions between clinicians and patients. And finally, the cultural beliefs that individuals have about antimicrobials, health, and disease. And so this is a problem that is shaped by multiple inputs, which is why I think we need an interdisciplinary approach to thinking about them, which is how I, as a sociologist, have come to be studying this topic. And so I've been doing some work, and this is actually a brief summary of a very large literature that is emerging to really show that antibiotics are sensitive to social context. And this is if you're interested in this in more detail, there's a chapter that I've written in collaboration with Jason Newland that's forthcoming in a Shea textbook. I'm not sure when that's coming out, but it will be soon, and if you're interested, I can send you a draft of the chapter in the interim, in which we go over the literature on the social dynamics that surround antimicrobial prescribing. So first, we know that antibiotic prescribing is sensitive to the relationship between clinicians. There's actually what's been described as something called prescribing etiquette, or what are sort of norms, or what's considered acceptable as far as interactions between clinicians about their prescribing habits. And so one of the key findings is that prescribing is sensitive to the hierarchy. So people who are lower on the power totem pole, such as trainees, are not comfortable correcting the behavior of people higher up on the hierarchy, such as attendings. We also know that relationships between clinicians and patients shape the use of antibiotics. If you ask a clinician why they overuse antimicrobials, they will say that they do it because they capitulate to patient pressure. But there's a growing literature to show that perhaps prescribers actually are overestimating patient demand for antibiotics, and this suggests that there's sort of a misperception and a mismatch going on in that interaction. We also know that antimicrobial use is shaped by more sort of psychoaffective dimensions, so risk, fear, and emotion, and that in the moment in which someone is making the decision about an antimicrobial, there are a whole host of emotional things that might be going on that will shape decision-making in ways that have nothing to do with what would be concordant with guidelines, for example. We also find that when you ask clinicians about antimicrobial overuse and sort of the roots of the problem, there's quite a bit of misperception out there. So it's sort of a NIMBY situation and not in my backyard perception that exists out there. So when you survey clinicians, they agree that absolutely antimicrobial overuse is a problem, but it's not a problem at their institution or in their own practice, even when given data to suggest the contrary. And so really there's a real perceptual issue. So antibiotics have a bit of an image problem, which is why, again, stories become important. And finally, we know that that prescribing is shaped by contextual and environmental factors. And so why do we need to tell stories about antibiotics? And I think I sort of previewed this with my comment about antibiotics having a bit of an image problem. So antibiotics may suffer from a tragedy of the commons scenario here, which is essentially an economics theory of a situation within a shared resource system where individual people acting independently according to their own self-interest behave contrary to the common good of all users by depleting a resource through their collective action. And so it's really this conflict between individual decision-making and the goals of the community or the group. And so it's this tension that goes on that you can see where an individual clinician is caring for a patient and they're concerned with this train wreck right in front of them. They're afraid of medical legal action. The patient's already deteriorated a number of times. Even though the cultures are negative, you want to do something. And that is far more emotionally gripping and more sort of salient in that moment than sort of this larger issue of antimicrobial resistance on a broad scale. And another reason why we need to tell stories about antibiotics to make antibiotic resistance real and feel real to people is that antimicrobial overuse and the development of resistant organisms are loosely coupled, and so it's difficult for people to see the consequence of their behavior. So risk in this case is either invisible or difficult to see, and the consequences of our action are far downstream from the moment in which you make a choice. And so we need to think about how can we get this problem to be more on the minds of people in their everyday practice, more on the minds of leaders and those who are tasked with marshaling resources to either support antimicrobial stewardship, change the food that's provided in a hospital cafeteria, or sort of make these big picture decisions that can have an impact on the amount of antimicrobials that are used in a facility. And so as I said earlier, as a sociologist, I'm a qualitative researcher, which essentially means that in my work, I basically talk to people and I watch them. So I hang out with them at work and sort of make sense of what they're doing, and I spend a lot of time sitting with them and having them tell me about their perceptions and thoughts. And so, and really, when I was asked to do this, I took a little bit of time to think about how I, as a researcher, as a social scientist, could comment on this, because I do gather stories for a living, but I don't necessarily use those stories to change things. I gather the stories in a systematic way to try to get a better understanding of something in the world. And so I gather stories for a living, but I don't necessarily move to advocacy, although I'll give you a case in which I did later on. And so really what is motivating to me is trying to understand behavior in social life as it's experienced by people, rather than in categories that I predetermine to be important. And so I think the important thing with stories is that they can really help identify unanticipated phenomena. They can help you see things that you didn't think to ask about. And so qualitative researchers use very exploratory, open-ended research questions that are committed to really an inductive reasoning approach. And the methods are suited to focus on either issues around which not much is known, topics that are difficult to operationalize quantitatively or to sort of capture in a quantitative format, and really understanding sort of the rich and nuanced impact of social context on behavior. And you'll see what I mean when I provide a few more data excerpts that you can sort of feel and see social context at work that if you were to reduce it to numbers, it would be harder to grasp at these dynamics. And so really, I care about human subjectivity, and I'm motivated at uncovering the meanings that people attach to events. And so in my dissertation research on infection prevention, I was trying to understand how people thought about hospital-acquired infection, how they thought about public reporting, and sort of how they thought about being held accountable for these kinds of adverse events that happen in hospitals. And I was able to uncover a lot of things that were counterintuitive that I think, contribute to the literature on infection prevention to show sort of the motivations that people have that are different than how we think people actually are behaving. And so the kinds of questions I bring to a research study when I first enter it is I ask, who are these people that I'm talking to or observing? How do they make sense of the situation that they find themselves embedded in? How do they perceive the world around them? And even if that perception is perhaps different than what I think or different what the literature shows, I want to capture that perception or misperception because the gap between what I think and what someone else thinks may be particularly important. I want to know what motivates people, and I want to know what worries them. And so in terms of the actual nuts and bolts of eliciting stories as data, I really think that, if this is something that you're going to go forth and do, the idea might be, well, how do I go ahead and get people to tell me stories? The reality is you can simply ask. That many people, if given the time and space and someone to listen to them, they often have an urge to tell you a story. This has been something that's been really gratifying to me as someone who primarily interviews healthcare workers. I've been worried, well, will I be able to get these people to talk? Will I be able to get my respondents to share with me the experience of medical error and healthcare quality, which can be a very intense topic to talk about. And never once in over 465 interviews I've counted has anyone refused to answer a question or refused to speak with me. And so I think that that's evidence to me that people have an urge and a desire to share if someone's willing to listen. And so some basic, simple prompts, you can really just start with something basic like, can you tell me a story? Can you share an experience you've had? If you're interested sort of in understanding a particular topic, you can ask people about turning points or sort of critical moments of reflection. You can ask people to recall a day or an event or a particular thing. And then you can sort of prompt people to think about emotional moments, because frequently emotional moments are more embedded in our memory and can allow people to speak with more detail and more nuance than less emotionally charged events. And so that's a good way to get people to tell their story. And so I wanted to present a story that was told to me by a pediatric infectious diseases physician. She was a participant in a study that I am currently finishing up right now on how antimicrobial stewards handle clinicians who are resistant to changing their prescribing habits. And this was a story that she told me in response to one of my interview questions. So JS is me. Can you recall a time in your practice of medicine when you've come face-to-face with caring for a patient with a drug-resistant organism? And this is about 3/4 of the way through the interview. And this particular pediatric ID specialist says, one of my first patients in fellowship was a little girl. I'll never forget this, and it was almost 20 years ago. She was 6 years old. She had cystic fibrosis and end-stage lung disease, and she came to my hospital for a lung transplant. She was colonized with a bacteria called Burkholderia cepacia that was multi-drug resistant. And they did the transplant, and they immunosuppressed her so she wouldn't reject the transplant, and the organism went everywhere. It was in her blood. It puffed out her wound. It was bilateral mastoiditis. She was very, very, very sick, and it was all ours, and there were no antibiotics to treat it. We tried an antibiotic from Europe called temacillin on compassionate use, but her organisms grew right up to the disc. And we tried it anyway, and she never cleared her bloodstream, and she died of Burkholderia cepacia sepsis, and it was horrible. We were packing her dehisced wound, her sternotomy wound, with acetic acid soap gauze, like they used to do during the Civil War on the battlefield, just to decrease the bioburden. It was horrible. And things like that aren't unusual anymore, to have an organism you cannot treat. When I try to be a steward for antibiotics and I get resistance from colleagues in other disciplines, I want to tell them this story because I just don't think they see this connection. Imagine how you would feel if you had to tell a parent, look, we know what your child has. We know what this bacteria looks like, how it acts, what it is doing to your kid, but we can't do anything about it. How would you feel? And so this respondent, I mean, I don't know about you, but when I even read this out loud, I get goosebumps. When this respondent told me this story in our interview, you know, it was an event that happened over 20 years ago, but she still had this really emotional response, and telling the story, I think, really brought up a lot of feelings for her. And so this is an example of a story, and I'm sure that clinicians all across the country have stories like this that we can capture, catalog, and use to advocate for the more judicious use of antibiotics and to think about them as a truly precious resource, and frankly, to consider the possibility of a post-antibiotic future, which is quite terrifying. And so I want to turn now, just to finish my segment of the talk, with a brief case study that's not about antibiotics, but is about an infectious diseases related topic, about how the systematic gathering of stories can actually help change policy. And this was a study that I was involved in during my time as a postdoctoral fellow in the Division of Infectious Diseases at the Children's Hospital of Philadelphia. And so I worked with Dr. Julia Sammons, who's the medical director of infection prevention at our hospital. Essentially, she came to me and said, Julie, we've got a problem here that many hospitals across the country have, which is that our docs and our advanced practice providers, our nurse practitioners, come to work when sick, and they care for patients when they're sick with colds, with diarrhea, with all kinds of problems. And we want to know why. Why is this happening? And she originally had wanted to do just a survey, and I said, okay, we can do a survey, but I think we also need to make sure that we have a component of our survey that asks people to talk about times in which they might have worked sick. So we designed a survey and administered it in 2004 at our hospital, and the survey had half fixed response questions and then 2 open-ended prompts eliciting stories about working while sick. The resulting study, if you're curious, has been published in JAMA Pediatrics. And you can see, you can read a little bit more about our study there, but I'm going to quickly give you the highlights. So essentially, what we found in our analysis of the closed-ended questions was not surprising as far as the fact that many of our respondents believe that working while sick puts patients at risk. So 94% of our respondents said, yeah, you shouldn't work when sick because patients are put at risk. We also found that despite this, 83% of our respondents worked sick at least once in the past year preceding the survey, and that 9.3, which was over 60 respondents, reported that they had worked sick more than 5 times in the past year. And we asked respondents to tell us what kinds of symptoms they might come to work with, and we were frankly pretty surprised at the level of significant symptoms that people would work with, including fever, diarrhea, and acute onset of significant respiratory symptoms. And, you know, this was definitely sort of sobering and is not unique to our institution. This is a problem that is common across hospitals. But the open-ended questions were really where the meat was, and it really provided us with some real intense insight into why respondents come to work when sick. And so we found that the major reason why they come to work sick is because they don't want to let their colleagues down. So it's a very strong social and group norm, prioritizing the needs of the group over oneself. There's a real strong desire not to let patients down, which is not surprising, and as a patient, I'm happy that my doctors don't want to let me down. There was a fear of ostracism that was communicated in these open-ended statements, that people felt like, well, you know, if I call out sick, I'm either going to be bullied or otherwise made to be feeling bad about this choice. People described in a lot of detail sort of staffing concerns and sort of the extreme difficulty they have finding coverage, which really helped us sort of get more of a sense of the system in which people were working in across the institution, and how complex it was, and how the change for this was not going to be a one-size-fits-all solution. Again, as I mentioned here, this feeling that there is a strong cultural norm to work sick unless remarkably ill, and finally, a sense of ambiguity about what constitutes too sick to work. And so people had a lot of confusion about what symptoms are too bad to work with, and wanted some clarity around that. And again, by eliciting people's perceptions, by eliciting their stories, we were able to uncover dynamics that would be hard to capture in another way. And so I just wanted to present to you two segments of data from this survey that I'm going to show to you, because I'll talk to you about how we advocated with these stories. But here, a fellow who was working in the ICU at the time responded in the open-ended portion of the survey. She said, one day in the ICU, several of us asked a co-fellow to go home because she was extremely ill with vomiting and diarrhea. She was so ill we had to place an IV to give her fluids, and we felt she was a danger to herself and to her patients. We volunteered to cover her work so that patients would be cared for. The chief of our division overheard this conversation and stated, when I was a fellow, there was no such thing as a sick day. As a fellow, hearing that from a division chief leads you to believe that there simply is no option to stay home. A nurse practitioner made the comment in her open-ended segment of the survey, I was trained that if you're calling out, you better be dead. It's a mantra that has always stuck with me. And we got numerous stories, a lot of IVs being placed, a lot of people working and darting to the bathroom with diarrhea, some really sort of intense stories in which people provided detail of their experiences with this very difficult choice. And when we gave this talk, we really labeled it between a rock and a hard place, because our respondents really described knowing what the right thing to do was, but having trouble making that choice. And so the open-ended data that we presented really captured that. And so we did the survey, we figured out the reasons why we were having this problem, and then we decided, well, okay, we need to do something with this information besides publish it, which we did. But we knew we wanted to try to change things at a local level at our organization. And so Julia Sammons and I went on basically a tour, a speaking tour across the institution. And we presented a talk that included a summary of the quantitative and the qualitative results from this survey, including actually telling stories like the ones I just presented to you at these leadership meetings. And I think we might have spoken at over 12 meetings, meetings of nurse leadership, the patient safety committee, division chief meetings, and we gave this talk multiple times, and we really felt like by presenting not just the statistics that we found in the survey, but the open-ended narrative data really led to an engaged discussion and was attention-grabbing. You know, stories do a good job at capturing drama, and drama it holds our attention. And this was something that we felt was especially true for the leaders of our hospital, who you have to remember, and your leaders of your hospital are the same way. These are very busy people. who have many other competing concerns, many other people needing their attention, many other issues that they need to attend to. And so to make your issue salient for them, we need to give it legs. We needed to give it something that was going to cause them to sit up and stop and say, you know what, this is a problem, and we can do something about it. And so after doing this tour around the hospital of speaking at these meetings, we were able to sit down with the leaders at the hospital to basically come up with some changed hospital policy and designing new systems that were developed to make it easier for staff to call out sick. And so as of this past winter viral season, the policies have been in place, and early reports suggest that they're being embraced by staff, but we're in the process of sort of measuring their impact. But really the key message that I want to leave you with is that, we used systematic methodology to gather stories, and then we painted a picture using quantitative data as well as stories to advocate for change about an issue locally. And it wasn't enough to just do the research. We had to go and take the research and the stories out to the people who needed to hear about it to get change to occur. So I'm going to go ahead now and pass the baton over to Evan Lerner, who's going to talk to you about communicating science using stories.
All right. Thanks, Julie. All right. So that's a good transition point because what I do, and I'll just remind you, so I'm a former science journalist, current science communications expert. I'm Director of Media Relations here at Penn, and what I really do there is talk to scientists about how to better write and speak about their own research using the conventions of storytelling as a way of better communicating to other scientists, but mostly to the public and people outside their fields about what they do and why it's important. So, the first thing I do, this is sort of a version of a talk that I give to them, to different groups here, about what a story is and how basically to think about stories and what makes a story a story. So this is a diagram from a English textbook where we really see that a story is just something that has three parts. It's a three-act structure. That's something that you would hear a lot of within sort of storytelling formats. It's got a beginning, a middle, and an end. And the part that we really care about is that middle part where something changes. Something changes in the middle, so the end is different from the beginning. There is, as Julie was mentioning in the last part, there's drama, there's conflict. Things are in opposition where an outcome will occur out of many possible outcomes, and we care what that is. We want to know what happens next. That's how we get people engaged in stories, why people like stories. So I use this a lot because I mostly deal with physicists and chemists and engineers. So this guy you may be familiar with, Walter White from the show Breaking Bad. This works really well with the chemists. If you remember the beginning of the show, this is a scene from basically the first or second episode where it's almost kind of a mission statement of the story where Walter is talking about his views on chemistry. And that chemistry is the study of change. He's basically setting out a mission statement for what we're going to see over the next 5 years, which is the transformation from this mild-mannered scientist into drug kingpin Heisenberg, and that is something that is completely engaged. That became the most popular show on television. People were invested in seeing what was going to happen next to this guy, and even Vince Gilligan, the showrunner, made it pretty explicit when he described the show as being a story about a man who transforms himself from Mr. Chips into Scarface. So we can use the principle of change and conflict in our own scientific stories, and we know that this works because of another guy you may be familiar with, Stephen Colbert. This is a little dated. This is 4 years ago, the last election cycle. This is part of the segment he did where he created a super PAC of his own led by the Ham in this picture, Ham Rove. And some folks here at Penn actually studied that segment, that series of episodes, and they found by even comparing it through people who had learned about super PACs through traditional news media, newspaper articles, and television shows, that people who watched this Colbert segment we're better informed about how super PACs work because, and this is a quote from, this study, which I can also send around, is that by walking us through the creation of the story and being a character in that story, it was engaging. Every episode was a continuation of that story. People, through humor and through seeing the conflict in firsthand of this character, better assimilated that information. All right, so we can apply this to your own stories and the stories that you gather from people in your line of work. So I'm going to actually just be going through sort of the big questions that you should be asking of yourself if you're writing something, or of a story that you're hearing, as far as, is this a good story? What elements do I need to focus on in each of these three acts, the beginning, middle, and end? So beginning part, we're setting the stage. We're getting to know the characters. Who are the characters in this story? It could be you. It could be the people you're talking to, and it doesn't need to be a person. In this case, we're going to have a lot of stories where characters are bacteria. And so what's going to be bringing these characters into conflict? What is going to be the problem that we're going to see in the middle that leads to one outcome or the other? And then most important, what are the stakes? What side are we on? Who cares about the outcome of the story? I mean, you could tell a story about deciding what you had for lunch today. The stakes are not very high for people outside there. So, unless there's a stake that your audience is going to care about, you can't answer that question, why should I listen to this story? That's really the big takeaway question you should have at this part of, justifying that it is a story that people should pay attention to. Okay, so the middle, this is a conflict. As we said, this is where the change is going to occur. This is the change that makes a story a story. What is that conflict? What are the outcomes? What was the outcome that was the result of this conflict? Who won? Did we win? The people that the people whose stakes that we're affiliated with, and why or why not? So again, to sum up, the question we're answering in this part is what changed? What was the thing that is going to make the end different from the beginning? So at the end, so we have closure to this story, but we're also, every time a story ends, it is implying the beginning of another story. So what's going to happen next? The desire to know what happens next is drawing us through the beginning and the middle, but the end is also suggesting another story that may begin. So we can revisit the stakes that we set up at the beginning. What happened to the characters? What's going to happen next to them? Are they happy? Was this the outcome that they wanted? And then, more importantly, what else could have happened? How could this outcome have been differently if this conflict had broken in a different way? And then the takeaway here, and this is really the important for the advocacy part, is like, what would we need to do differently next time to achieve a different outcome, or to avoid that conflict? If all the outcomes are bad, let's say, and that's the thing that you are going to want your audience to really take away from your story. So as far as this part of a sort of workshop, you can use this principle, going forward with your own stories, is I'm going to start to diagram a little bit out of one of the stories that Julie told in her segment, which was that, very sad, tragic story of a 6-year-old who, who died of multi-drug resistant bacteria. So here's the beginning. Characters, very clear. The little girl, 6 years old, is our protagonist. But also, note the word my. I mean, the person telling the story is involved in this too. It impacts her. And then, we have a non-human character here, the villain of the story, this terrible bacteria. What brings them into conflict? It's a multi-drug resistant bacteria, and this patient is immunosuppressed. We have clearly a conflict brewing between these two factors. It's the problem that we're going to the healthcare workers in this situation are going to be fighting with. What are the stakes? This one is pretty clear. Someone's life is at stake. That is pretty high stakes no matter how you cut it. And with its 6-year-old child, answering the who cares question is not very hard. I mean, I imagine that some of you are not working within human health, but in this case, it's almost cheating how clear the stakes of what and why we should listen to the story as a child's life hangs in the balance. I mean, this is easy mode as far as storytelling is going. Middle part, conflict. We have actual conflict in this story. I mean, we're making allusions to the Civil War. The drama that Julie mentioned as being something that draws people in, there are vivid, rich descriptions of violence, occurring here. That is you know, something that you should be pretty familiar with if you've seen any kind of media story, fiction or non. You know, it's what we call in journalism business, you know, if it bleeds, it leads. Those are things that that absolutely keep people engaged. You know, what outcome occurred? You know, and who won? Again, couldn't be clearer here. The worst possible outcome that we could see occurred, and it's right there on the page. And so did we win? We did not. We very emphatically did not win in this story. It was horrible. There was, you know, the stakes couldn't be higher, and we did not win. So that is, you know, a very clear example of showing the conflict in the middle of the story. The climax, what changed? A child has died. There's really not, I mean, again, you may not have as clear of a stakes here. Even if the story is a disaster was averted, you know, still you don't want to have a near-death experience or the consequences of even when things are not you know, the worst possible scenario. There are consequences that we can talk about. So the end. We're going to be really moving on to like what we can take away from this story. What's the next thing? You know, revisit the stakes. Very clear. We're not happy with this outcome, and you know, this is the most salient point I think from what Julie was saying is you're like, you know, I'm trying to be a steward for antibiotics because of this, because I saw this occur. So we're not happy with this outcome, obviously. What else could have happened? Here's the part where we call for change here. You know, things like this aren't unusual anymore. We have to have an organism that you can't treat. How would you feel in this situation if we had better antimicrobial stewardship? If we weren't dealing with multi-drug resistant organisms, this child may have lived. All right. What do we need to do differently next time to achieve a different outcome? I mean, this is where you guys come in. This is the advocacy part that I understand as being, you know, the focus of the stories that you may be crafting in the future. What we need to get across, what is going to be different next time, and why we should change the things that we can change in the relation to these stories. So. It's a framework. I mean, you don't have to, if you're writing a story, if you're retelling someone else's story, you don't have to hit all of these bullet points. But if you think in terms of conflict and these three-act structures and the driving, motivating force of a story of getting an audience to care about what happens next, you can start thinking about your own stories in this format and emphasize those things that will help draw us through these three acts and really emphasize, you know, why we should listen and what's going to happen next. So that's my part. I think we're, you know, that's our thing. So I'm going to maybe pass the ball back here. I don't know if I have to do anything, but yep, we're good. Thank you, everyone.
Great. Well, thank you so much, Julia and Eric, for that, or Evan, excuse me. At this point, you know, we would like to leave some opportunity for questions, but the CCCAS Collaborative had heard Dr. Szymczak speak previously and had the opportunity to think about her guidance and that was just provided by Evan on how to leverage the real-life experience of clinicians to assist in motivating change with administrators or with policymakers and beyond. So in order to do so, this resource, which I've included in your chat box right now, if you want to download it yourself, was created as a way to distill this kind of robust amount of information that was just provided into one kind of real tangible resource to help clinicians develop their stories in a way that is compelling by using facts, using data that exists to tell that story. So similar to what Dr. Szymczak had done, we took a story from a CCCAS Collaborative Steering Committee member, Dr. Scott Weissman, who had provided his story. And you'll see in the column on the blue, we provided guidance on how to develop your story or where kind of examples of how his story addressed those particular prompts. Of course, this is all very technical in creating a story, but really the best stories are the ones that are telling, you know, your personal experience. And so as a strategy, it can be really helpful to draft your story first and then go back and evaluate and to see if you've addressed some of these prompts so that your story is as compelling as it can be. So this resource actually walks through those different prompts and then provides a list of some of the most current science-based key facts based on antibiotic resistance, with an emphasis on how antibiotic resistance or how antibiotic use in animal agriculture is contributing to this issue. There's some important and less utilized or less talked about information about the use in animal agriculture that can be very important in addressing antibiotic resistance in a compelling way. The last piece of the resource talks about, now that you have this story, what do you do with it? And there are ways in which you can deliver that message, whether it's through testimony with your legislators, as some CAUSE collaborative members have done, whether it's communicating with your colleagues. It's actually not widespread or widely known by clinicians, the proportion of antibiotics used in animal agriculture as compared to clinical care, because the emphasis has often been on judicious use in clinical care. It's only until recently that we've had data to give us information about the proportion being used in animal agriculture. Also, again, in your hospital, we have some examples of hospitals throughout the country who are passing resolutions that are phasing out the purchase of meat raised with routine antibiotics as a way to address that side of antibiotic misuse. And then also in your community, telling your personal story, how antibiotic resistance has personally impacted your experience, and is an effective way to connect with your patient's family and community at the individual level. One piece of note that we do provide in here is to ensure that once you've compiled your story, you've addressed it for these different criteria, that you review it for HIPAA Protection Act to ensure that you're not divulging any private information of particular patients. So we provide guidance and a resource on that front as well. And so as an opportunity to actually dive right in and put this into action, the CAUSE Collaborative has championed an activity every year in collaboration with the Center for Disease Control's annual Get Smart About Antibiotics Week, which is an annual week to bring awareness around the issue of antibiotic resistance. The CCCAS Collaborative in particular creates opportunities for clinicians and others to take action on the issue of antibiotic use in animal agriculture through discrete activities. And this year, we've created an opportunity for you to submit your stories about antibiotic resistance. So putting this actual document into action, creating your stories, and then submitting them, at which point those stories will be used to create awareness and education during the Get Smart Week, which is in November of this year. So you'll see the link here on the page to access the site where you can submit your stories. On the same page, you can access that storytelling resource that I just provided some background on. So at this point, I encourage everyone to please send your questions or comments, whether it's directed to Dr. Szymczak or Evan Lerner, as well as this resource and action opportunity in the chat box, and we'll provide some opportunity for answering those questions.
I'm just unmuting our speakers. Please send your questions to me through the chat box, if you would.
And as we see if anyone has any questions with regards to any of this, I do want to mention that this session will be followed by another session on October 4th, targeting food service directors and food service staff and assisting them in their opportunity to market and educate their efforts to source meat raised without routine antibiotics.
I don't have any questions that have come in to the chat box yet, but Stacia, do you have any?
This is Julie. We also are happy to take questions by email if people would prefer to do it that way. We can put our email. I don't know if can I type it into the chat box? I could do that.
You can.
Oh, that sounds great.
Oh, wait, we have one here.
Oh.
There, start to come in. Okay. So this might be a question for Saul, but maybe you all have something to say about it. The question is, what are some of the challenges that you've encountered in taking a story and translating it into policy action?
That's a great question. This is Saul. I have never personally been able to, really. So I mean, I think that's part of why we're doing this webinar. I don't know if Scott Weissman's on the webinar. I can speak to that because he gave one.
He is here. Scott, I can unmute you. I'll do that now. Scott, do you have anything that you wanted to share in terms of experience in taking your story into policy advocacy?
Julie, this is Julie Szymczak. I did want to just make a point about, just to respond to that sort of tangentially, the story that I told, the case study that I brought up about the staff illness. I think, you know, one of the challenges is really getting the policymakers, the people who either control the purse strings or control the policy or control, you know, who have power, as I think I mentioned, and I think it's really important to remember, have a lot of competing interests. So you may be passionate about your cause and passionate about your one particular issue, but you have to remember that they have a whole host of issues. They're all kind of competing for their attention in this limited attention space arena. And so if you kind of think about it that way, it can also help you, you know, get over barriers in relation to actually changing policy with stories. I think that doesn't really answer the question of an example I had, but it's an important thing, I think, to mention.
Hi, this is Scott. I got so excited that I disconnected my audio. I guess I would say that when you go from, when you're trying to implement, you know, an advocacy position, whether explicit or implicit, through storytelling for policy purposes, I guess there's the, you know, all your potential baggage, whether it's real or perceived, come with you, and, you know, the audience in a policy discussion is probably going to be quite different than the audience in a, you know, a less charged or less purposeful setting, like if you're just speaking to a lay audience. You know, so I think it takes great care to tell your story with all the meaning that is authentic to you, without, you know, falling back on cliche, or without resorting to things that are too explicit or overt that could lead people to, you know, dismiss the essential subjective truth, the authentic truth that comes from your story. I think it's very delicate. And takes, you know, probably iteration and some rehearsal to make sure that the notes you strike are really authentic, so that you don't end up, you know, becoming so easy to, I guess, dismiss because of fitting some stereotype.
One thing I thought to add, from the perspective of those within Healthcare Without Harm working to support hospitals in some of these changes, is that, you know, in making policy change, whether that be at the, you know, federal, state level, or within an institution, it's a multi-pronged process. And so the ability to have someone on the front lines telling their story from a personal perspective, and also from, you know, backed up by research, may be what actually propels, you know, months or weeks of work into action, where there's been discussion and kind of, you know, a recognition that there's a need to do something, and this might be what propels people into actually, you know, taking action on that issue. It's hard to say if any one kind of story that was told or any one testimony was the linchpin, because oftentimes policy change takes a process. But I certainly feel that when people come to the table and tell their stories personally about their experience with the public health issues that may be at hand, there's an opportunity to propel action. Okay, so with that, I do want to thank our speakers, Dr. Julia Szymczak and Evan Lerner, as well as Dr. Saul Himes, and thank you to Dr. Scott Weissman for jumping in. For those of you who are interested in following up, we will provide a follow-up email to all attendees, and we'll include the email addresses of those speakers today. In addition to links that were provided in the webinar, we'll provide a copy of the webinar slides. So thank you again for joining, and we hope you'll visit us again in October for our session focused on food service directors and staff.
Thank you.